study and make an impact on EDS, and so they want to devote their lives and their careers to this, and so we want to give them that opportunity. So we do that. This is the second year we just finished our intern program. This is 10-week program. Criteria are you have to have EDS, and you have to have a passion for wanting to make an impact in the future. So going into healthcare, medicine, research, physical therapy, education, outreach, anything that is related to something that's going to spread the word is really, so critical, and so that was part of the requirement. Kids are bright, way smarter than me. Like unfortunately, we had so many applications, we had to turn down the vast majority of them because we could only have 5 students, and so there were 45 students that we actually had to turn down. And the ones that we turned down, some of them, their second choice was Harvard, Mass General, Stanford. Those are amazing, amazing programs, and they wanted to come to us as their first choice. And so we are trying to encourage other institutions across the country to do that. I've been trying to engage the EDS Society to have money and funds to have calls out to other institutions globally to be able to do this. Because a lot of these students will do it volunteer. They don't even need the money. They just want to be part of that process. And so, I hope we become the poster child for that as an education opportunity, and with the goal of when they finish medical school or health professions or whatever their future career is, that then they go on and educate the next round of 250 physicians, medical students, or 100, physical therapists, whatever. And so then your knowledge grows. So I think that's really important. We also have to. One of the other things that we've done is to go to the medical schools and say you need to change your curriculum. So when I gave a talk to second-year med students this past year, and I'd always heard that in their education, when they're taught about Ehlers-Danlos Syndrome, it's always one line on a slide, and that's it. And I talked to we had some medical students in the lab, and I said, I want to see that slide. Like, I'm telling people about this slide, and I've never actually seen the slide. So I said, give me that slide, and I'm going to use it in my talks. And so they sent it to me, the actual slide that is presented by professors at both MUSC and USC School of Medicine. And it's the same slide, and it says Ehlers-Danlos Syndrome is a rare connective tissue disease that's characterized by loose joints and stretchy skin. Period. That's it. And so you're never going to see it. Even if you do see it, it's benign. Who cares if you have some loose joints, and maybe it's an advantage that you have this. And so I'm like, okay, stop feeding medical students wrong information. You have to be current. And so we've made a move now. We've already received the commitment from Donna Kern, who's the curriculum committee head at MUSC, who decides the curriculum for the medical students. She's going to change and let me teach an entire lecture on Ehlers-Danlos.
Great. That's great.
So that's really good. And the other thing that we're doing, I think that's is probably going to be, my biggest legacy, maybe, is we're just one research lab. I have a great group of people that are really smart, but we're just one group. There's too many questions to answer just from one group. We need more of us, right? All around the country. So we were tasked, this is a few months ago, we were tasked by executive leadership to develop a pro forma vision for an ask to the federal government. And so we put together a pro forma, where it's an ask for $60 million to go into the President's federal agenda book, which would then be lobbied on Capitol Hill. I originally thought this was a $60 million ask for MUSC. Like, yes, that's what we need to build an institute. And it ended up being lobbied on Capitol Hill. And as of July 5th, it made it into the House of Representatives Appropriations, Department of Health, Labor, and whatever the book is called. It's on page 148 if you want to look it up. It has our wording in there as an encouragement to NIH to make this a line item. A $50 to $100 million line item in the NIH budget to build centers and research partnerships across the country to build more labs. And so, if that, well, I hope it does happen for many reasons, and I also hope that we get some funding. You know, executive leadership is really behind this, and I don't know if Pat Colley will be here tonight. He's supposed to be here as the CEO of MUSC. He's hopefully going to be here. I don't think he'll talk about what we're doing, but there are some other big plans in the works that we hope will really make an impact for clinical care and management and research for the EDS population. So the paper describing the gene, everybody wants to know when this paper's coming out. I want to know when it's coming out too. Will be submitted in the next couple of weeks, so it's good.
Are more participants allowed in the study that you're doing?
The study is currently, yes, still enrolling. It will probably start to phase down because it's we're playing a lot of catch up. You know, I have 7 clinical coordinators, which is more than most departments, entire departments have, and it's a huge cost burden. I mean, we are completely funded through philanthropic measures, and you know, to have it keep going. I would love to have it keep going forever and just keep growing. But realistically, we need to spend some of those funds on that, you know, the outcome of what we have from those samples. So right now we have about 5,200 enrolled. We've done full consents on 1,700. So you can see how much we still need to catch up. I think what the plan is we'll probably still be consenting. We just won't be collecting DNAs or salivas, because that's, just so you know, it's $30 just for the tube and the shipment on average. And some people don't even send the tubes back. About 30% that we send it out to don't even send the tubes back. Yeah, I know it's shocking, but it's sort of par for the course, I guess. And then some will send out 2 or 3. So it just gets really expensive. But we are interested in the clinical demographics of I have talked too much, but Dr. Francomano just walked in, and we're going to wait until she gets her talk at 6:30.
6:30, yeah. And there's snacks. Yeah, there's everything outside if you want to grab some.
But if you, so the lab is always open. Well, it's not always open. You have to have badge access to get in. But if anybody wants to come see the lab, you're welcome to. I'm happy to give. What? Oh. Yeah. So we say yes.
Yeah.
Okay. I think it's important to bring the public into the lab and see the lab and see where we're making these discoveries, how we're doing it. We're not going to get too technical, but you can see, the different areas of the lab and how it's set up. I think it, helps put a little bit of context. We show you the whole procedure, like what happens with the saliva when they come in, where do they go, what's the next step, where does the DNA go, how do we do the DNA? Isolation, what then happens after that, and so we can take you through the lab. So I think we're a bit unusual in that we do have the lay public come through and see the lab, but I think it's also important, and it's it also shows you our commitment to this disease.
We're so blessed to have you. This lab is amazing. Amazing work going on.
So if you have any questions, I'm happy to. Then we'll go on to about 6:30, I guess. Everybody else to come.
Hello. I knew.
Sure. Okay. What's your name?
Oh, okay, great.
She should hopefully be here. Great, great.
25.
The paper. So that's not going to be. So the process of the publication is we submit it to a journal, and then it goes through an editorial review, and then if it passes, it goes out to review, and then it sits there for a while, they go back, and then back to us. We're not sending out any reprints. We're not allowed to send out any reprints of the gene thing until it's actually. And unfortunately, we have no prediction. All we can control is when we actually submit it, which will be before the ESO.
If you can, you have to stay like in the ballpark, just like
We want to. We know people are. Yeah, it's everything's actually done. There's little minor. Test.
And then I just called them. And then I had to talk to Chicks to make sure we got it. It's great to see you. Okay, thanks.
Yeah, absolutely. It's just in a village. It sure does. How are you? Good. How are you? I know I didn't say anything about it, but I didn't want to make it awkward.
For those watching at home, we'll be starting at 6:15. For those watching at home, 6:15.
I saw her on the Olympics. I'm like, okay, I know where that is. So let me come here. And then I come home and it says, oh, there we go. And then I tried to get it. And I'm like, no, this place is locked. I'm like, okay, seriously? So you weren't wearing a light. 13 years ago. Crazy how different.
have some that look like they're diagnosed and then there's others who are diagnosed and kind of have a small heart, like, it's just been very nice.
You live here?
I had to think about it when I was picking it in, and I really saved myself a few times to see over it.
Really, sorry, I was supposed to come.
But she told me that it was hypermobility and I shouldn't place anything under any. The 9 and 18 what an odd combination for this. That's what I was told at first. Who was told this? It was, was it a herpetologist? It was a herpetologist. Was it, what's the name? This was the herpetologist that,
It's useless.
yeah.
I don't remember.
And
A little warm. Oh. I'm super helpful. I mean, I could look it over in the bar, but I don't want. It's all good. It's all
Yeah, we don't want to start too soon.
And of course, you know, everybody says, well, you're in your 60s, so it's normal, you're going to have bad knees. And
I was like, that's not true.
and the pain has been, you know, it didn't start. It started.
Yes.
Gymnasts and everybody that does all that crazy stuff, most of them,
And they think it's wonderful that
and
they
they're
can do it.
so flexible. But they don't realize they're nobody knows to tell them. But I went to see a hand too, because my fingers not go and my thumbs go out of joint. And one of the women said,
Yes, I remember after.
this could be. And I said, really? Because I don't know a lot about it. But you need to go see a genealogist. So, which I couldn't do through MUSC.
And I just wanted to say hi.
And most genealogists pediatricians. Dr. Pye, pediatric.
You're okay?
Right. And my daughter went to him. She doesn't have EDS, she has something much that's not studied anywhere, and 200 people in the world have had it.
Oh, wow.
So, it's called Ehlers-Danlos Syndrome. Nobody knows about it. I mean, it's so, and it has a connective tissue part, but it also has developmental disabilities and motor skills.
I think that I met when I
And, you know, doctors she's not walking because she's a
specialized
baby.
in girls. And she knew
So she's walking like, and just
then
think
she
about
stopped
that.
working.
But that's what got me into it, and so I went to see Dr. And even at 64 years old, I was 6 out of 9 organs.
Which, here, what's his specialty?
That's
That's the one, okay, that's the one we went to.
And he immediately said, you have pets. I mean, you're hypermobile. Because you have 63 without stretching. You know, I'm like, can you do that? Like, just bend over and get it.
That was the only thing I couldn't do.
Yeah.
I was almost trying to, that was the only thing I couldn't do. Was reach down.
Right. But the thumbs and the everything, you know.
So orthopedist, then genetics.
And then, actually before the choices, I was looking for a primary care doctor, and it turned out that, because mine was retiring, I got Sylvia Clarkson, who is in Mount Pleasant, MUSC primary care. She was Susan Chalela, primary doctor. And so I got to her, and she's like, you need to go see Susan in the fall start. And I'm not ready to have braces. I spent yesterday and today trying to
Oh, no.
So
You had some good days.
yeah, and I went down the steps about 3 minutes.
On Joy Strauss.
Sorry,
Joy. I try and make it.
Start with the Y. We have to know what. You said
I have Chiari and Tetrafor and Ehlers-Danlos.
Priscilla.
Mast.
Sherry, I want to introduce myself. This is my mom, Priscilla Holtzbach, Chip Norris, and my husband Kevin.
Hey, nice to find you.
This is the other daughter, Katie.
Because I have cirrhosis.
So they hear your name
Interstitial lung disease.
frequently, so.
And because I had.
We're trying.
So I had my
Yeah.
first husband.
Anyway, I
Charles
just-
did an amazing job.
She's
But see,
been,
I get treatment.
love her dance as well.
He's been great. So,
Because I was 6 months when me and my were trained. And that was in 2000. And here I am with normal blood pressure. I know. I also.
We've been enjoying the baby lab adjacent.
Yeah, I don't drink. I don't do anything. Do everything before.
Yeah.
Or even on.
you know, I think that our genetic study is not
You know,
playing
and it all, anything in your skin is absorbed.
It's at least a start.
But it's come so much farther than what you
So it's a lot of,
trying to figure out.
I've had to research on my own and.
Yeah, you know, I think if we're successful in building an institution,
It's great. Medical education.
it's gonna really, I mean, having embarrassment like you know, it's just all of the,
Dr. Patel. Patel started school a year ago, and finally when he told me.
Such an important part of your well, but it's also the parent. What you have to deal with it.
Great. There's
My
so
brother
much
had
there.
it. We're both athletes.
But a
There
lot
needs to
of
be an
PDS
support
has
for
scoliosis.
But as my dermatologist says, it's in the.
So, that has so, yeah, I'm hopeful.
Children.
Yeah, yes, I've got a 15-year-old daughter.
So you're saying.
79-year-old son, and I've got
Yeah, spent a lot of my own
More
on
GI manifestations.
Yeah, I have a lot of GI.
The
And there's
EDS.
no GI doctor here
And so
that
is
knows
somebody-
anything about EDS.
fighting hard. But
Being groomed by us.
it'll.
Good, good. My liver doctor
Well,
actually
even
did.
just like Charlotte this year, we first got to like real special together, like could we feel like a good heart disease?
They tried to send me to a
If we
regular
could have
GI.
been able to
Dr. Warner knows everything.
all in the same place and have them communicate with one another and to check for all of this. What a difference that would. Is Courtney coming? I know she went back
yeah.
Every 6 months. Really?
You don't have to.
See, Dr. Warner still does it. Really?
It's nice to meet you. Because there's a risk of
Perforation. But he does.
and he, Dr. Flores, consulted all 6 doctors that were in his practice.
Said risk benefit.
Yeah. Right. Dr. Wilner did, like my last, he also does an endoscopy every 2 years because of esophageal varices and
Endoscopies, like he's supposed to do because there's less
upper risk.
risk.
Right. But they tested me for mast cell when they did the endoscopy. They took this stomach virus.
What was the standing?
I don't have a clue. I'm unconscious when they do that.
So they're, right, it's different. Yeah, and it's supposed to
He did that and he tested me for celiac, which is an esophagus. But he was willing to do it, you know, as a liver doctor. So when I said, it's related to the and I said, I've been seeing him for 22 years. I mean, it's like his family. Every 6 months for 22 years, that's a lot of visits.
So it's a personal friend, not a doctor.
So Ira, can you just take care of my GI issues?
That's my.
Because you had to be a gastroenterologist before you became a gastroenterologist. And I said, yes. How are you doing? How's your brace?
Not on.
Is your neck feeling any better at all?
I'm doing okay. Not really better.
I know.
I'm like here, so. Your hair's blonde.
it's the seating looks at it.
I like it. You look really cute. You look like a little southern gel right now.
I've always been allowed to.
We bought a townhouse off of Covent Garden. It's actually quite
Get to the right, or the right specialist that can say,
That's her sports medicine doctor.
well, that's exactly it. That's what they always said about my doctor, because she broke her ankle.
And when she went to physical therapy, she went to one session, so she didn't have
She's here and she's not wearing her brace.
I know, it's distracting. Can't take her anywhere, literally. Yeah. Well,
Well, you're taking her to Roundup.
didn't you like tell one of those?
Partly because there's a bed and like being required by her at some point there was like.
Right. I'm going to Dublin next year.
You did not. You upgraded? I thought you weren't going to do it.
But I thought that if you start having
Did you justify upgrading by using me as person?
no, but maybe you could justify it.
By laying down on the flight.
Yeah.
Yeah, we're supposed to go
I mean, I think, I'm not sure you get a lot of pay. But if you do start having problems, then it's going to help you out. Let's see how the emergency rooms are in Europe.
No, don't say that.
Pay cash there. Wear your braces.
Do you have any questions? I wish you could have methods.
Yeah, so they're going to be a few minutes of patient testimonial things. And then, we're happy to
Not great, but. What? Yeah. When I'm able to go to labs somewhat. A lot of the new things going on too, so trying to get it.
maybe it'd be good to talk to the three of us and something, you know, after you get back and settled and family.
Oh, really? And not,
Actually, that's a really good point. They were tested for Ehlers-Danlos Syndrome, which is definitely connected to the panel.
All right, guys, we're going to get started. I'm Juliana Wenninger. I am the walk chair this year, and we're just going to talk about the walk really quickly. For those of you who don't know, we do a walk each year for the Bobby Jones Foundation called the United Night Walk. This year, it's going to be on Saturday, September 24th. Registration starts at 3:30 and the walk starts at 5:30. And it's right there. It's going to be at the Medical District Greenway. The walk is all mobility aid and wheelchair friendly and totally optional. So like, don't feel like you can't come if you can't walk. It's totally fine. Yes, perfect. Yeah, there's a QR code on there for you to register. Like, you create a team. Kathy has the shirts for this year. Yeah, they're awesome. They're cute. So yeah, there's gonna be food, there's gonna be raffles, we have a bunch of great raffle prizes this year. We've got face painting, we've got music. And it's also just really nice to come out and meet other people who are going through the same things as you. People who understand, kind of like the support group for the people who were here tonight. And so, yeah, I just really encourage everyone to come out and support this wonderful foundation who comes out and puts on all these amazing lectures for us. If you have any questions, my contact information is on there. Nancy's contact information is on there. We're both walk chairs, so you can contact either one of us. But yeah, we really hope to see everybody out there this year.
Thanks, Juliana. So I'm Kathy Posnick, and I work for Bobby Jones, Carey, and the Myra Foundation. I live in Twinsburg, Ohio, which is right in between Cleveland and Akron. And Twinsburg is home of Twins Day. If you have those twins in the river run out there, it's great. Largest gathering of twins in the world. So I have, just so you know my background, I have 3 boys and my husband, we live there, but I have 2 boys with these disorders. And our family's experienced some dark days, and my boys are now 28 and 26, and they're working, they're functioning and stuff, but still as a mom, it breaks my heart that there's still, underlying issues. That just doesn't go away, even though they're doing better than they did years ago. So I've been working for Bobby Jones probably about 11, 12 years. Before that, I was a volunteer. I was on one of the boards. As soon as my kids were diagnosed, I wanted to get on the board to get to know physicians and other people that were dealing with this. So I got involved pretty quickly. I think it was like almost 17, 18 years ago. And it's led into a full-time job for me, and I predominantly oversee all the walks that Juliana was just talking about. So that's kept me very busy. And I'll just tell you a fun fact about it, because we're in our 11th year of the walks this year. We started in 2012, had 17 walks, and we raised $77,000 that first year. We have now held over 425 walks around the country, and we've raised over $1.3 million. So, we appreciate all the walk chairs and solo walkers and all the people that come out and participate. These United at Night does help support educational lectures like this and research that's going on. So very important work, so we appreciate the support. Even if you can't come, register, walk virtually, raise some funds. You get a t-shirt if you raise $50 with a light-up item, and there's also other recognition prizes. So Bobby Jones was founded in 2007, as many of you may know. And, one of my other jobs is to help with compliance. And, I'm always really proud to say that, we are we're the only organizations that have the BBB. We meet all 20 rigorous standards for the Better Business Bureau. We have the Platinum Seal from GuideStar. We have the Health on the Net Code. They're on a little break right now because of COVID, but we've always had that, which means physicians have reviewed our materials, and anything on our website is reviewed and dated, and we have to keep that updated. We have Charity Navigator, so that's all things that make me really proud, to be part of this organization because of the accountability and for, everyone to trust us for what we're doing. You guys may or may not know, Bobby Jones was the Babe Ruth of golf in 1930. The reason his name is in our organization name is he had cerebral myelin, and he was a visionary behind the creation of the Masters. I don't know if any of you guys know this, is kind of fun facts. And he was the only one that did the Grand Slam during, it was 1930. He won all 4 major tournaments, which is called the Grand Slam, which is a pretty big deal. And his pain management during his time was limited to codeine or whiskey, as syringomyelia consumed a little bit of him more and more every day. And then eventually in 1971, he passed away. And I think we're frustrated because 70 years later, we still don't have acceptable treatments for these disorders. And, we hope the work of our organization is going to help make changes. And since I've been around, I have seen such great changes in some of the research being done. I'm not going to go into, we do these educational lectures. We have a lot of great research going on. It's all on our website. I'm not going to go into detail, but there's some really good stuff happening. Get involved if you can. Get on the registry. There will be a huge help, and it's going to help move this whole figure out these disorders along. Next, we want Ella Grace to come up. She is going to tell her story. Oh, you said you're 14?
15.
Sorry, I'll let her tell you. I have a great memory.
Hi, my name is Ellery Aikman. I'm 15 and a 10th grade honors student at SOA. My issues started as a small child. As long as I can remember, I've had headaches that can sometimes get so bad they even make me throw up. My body hurts at times too, mostly my back, neck, and joints. I've always gotten really tired or hurt from doing things that don't make other kids tired or hurt. My parents recognized my symptoms as being very similar to those of my Aunt Kristen, who had already been diagnosed with EDS after suffering and searching for over 10 years for a diagnosis. When my mom brought her concerns to our former pediatrician and told her that EDS was in our family, the pediatrician completely brushed off my symptoms without even doing a Bateman scale, telling my mom that there was no cause for concern. She even told my mom that circus people have EDS, and I looked fine. My mom took me a few hours away to see another pediatrician who also has EDS. She saw a lot of things on her exam and did a Bateman scale, and I scored a 9. She told my mom to take me to a genetic specialist, and we traveled to Maryland to see my aunt's genetic specialist, Dr. Francomano, who gave me my EDS diagnosis. Since that time, I've seen a lot of doctors and had a lot of tests, some of which are very uncomfortable. I have a trick that I learned to do when I have something that is uncomfortable. I smile and pretend I have superpowers and try not to cry. I think of something happy or imagine something cool. I taught myself this when I was really little and I started having headaches. Back then, I even called myself Supergirl and said my superpowers came from the back of my neck, and that is why it hurt so much. When I was 6, my symptoms increased with constant headaches, pain in my neck, back, legs, and stomach. I even had short and long-term memory loss and brain fog. After lots of travel and uncomfortable tests, we found out that I had Chiari malformation and occult tethered cord. I had to go to New York for tethered cord surgery because at the time, Dr. Patel was not doing that surgery on EDS patients yet. I remember counting down to my surgery and not even being scared. I just really wanted to feel better. I even sang Frozen songs to the doctors and nurses because I was so happy. When I was able to go back to school again, I felt like a regular kid, even able to play again. The teacher who knew me before my surgery said I was a walking miracle. Through my journey, I have learned many things and realized that I have many blessings in my life. Here are just a couple of my examples. Medical professionals, teachers, friends I have known, and my parents who never give up on me and help me through my journey. Special shout out to Miss Susan, my PT, who has kept me out of my surgery for 3 years. My educators who work with me to assure I have special accommodations in my IEP and understand and support me when I'm not feeling well. While most kids take going to school for granted and even complain about it, I realize what a blessing it is to go to school. Organizations like this one that are dedicated to educating about these conditions and doing research to help patients like me have hope for the future. I am grateful for the research that Dr. Norris and his team are doing and for the donors who are supporting their research. Along with these blessings, some of the things I've learned. I have been bullied at times by people for being different and needing special accommodations in school. This has taught me who my true friends are. I learned that often plans to do fun things do not work out because someone might be having a tough time. We have 4 kids in my family, and my mom and siblings also have EDS. I know how special it is when fun things work out, and I have learned to appreciate those times and not take them for granted. I learned to focus my energy on positive things and things that matter instead of the things I was missing out on. I learned the difference I can make by being an advocate and telling my story. I know this is not the end of my journey, given the nature of EDS, but I have so much hope for the future. I know that God has been building my path and giving me strength to push through the tough times. There is so much more to my story that it would take a long time to tell it. Thank you for listening to what I had to say tonight. I hope it helped you see that you are not alone in this journey, and know that there are many people who see us in what we go through and are dedicated to work tirelessly to help us find answers. Knowing that helps me to have hope that I will be able to live a fulfilling life.
Hard to follow, but my name is Dan Judge. I'm a cardiologist here at USC, and it's almost a cliche to start off an introduction by saying it's an honor. But this really is an honor for me to introduce Professor Clair Francomano as the speaker tonight. I've known Dr. Francomano for many years, and I'll keep this short because I think everybody knows who she is as one of the world's best experts in the connective tissue disorders in general and for hypermobility in particular. Dr. Francomano has an all-star CV. She trained at Yale for her undergraduate and then Johns Hopkins University for her medical school, and then stayed on at Hopkins for internal medicine training, followed by genetics training. She joined the faculty and wasn't immediately involved with this condition, hypermobile EDS, but started in another disorder that's well known called Marfan syndrome. And she was the last author, senior author, on the most important paper that identified the gene abnormalities in fibrillin 1 that cause Marfan syndrome. She's focused on connective tissue disorders, including Marfan and Loeys-Dietz and other conditions that fit into that aortopathy spectrum. But that led to her interest, I think, in connective tissue disorders generally. She's also known for work in skeletal disorders and other genetic disorders, even as rare as Alström syndrome, which I found out this morning is one of her areas of expertise. She, after working at Johns Hopkins for several years, spent about a decade at the NIH in the intramural program and did some great work down there, moved up to Johns Hopkins in one of the affiliates and directed the genetics program. And about 3 years ago, Indiana University was really fortunate to recruit her. And now, as many people know, it's not just those who drive from South Carolina up to Maryland to see Dr. Francomano. It's about a 2-year wait to get in to see her in Indiana. And I think everybody around the country, now that she's in the middle of the country, can go to see her there. Dr. Francomano is one of the world's best clinicians in hypermobile EDS in particular, and I'm thrilled to introduce her today as our speaker. Thanks for coming. These slides, are they ready?
Thank you so much, Dr. Judge. That was really very, very generous introduction, and it is such a great pleasure to be here with you today. It's hard for me to follow that Ella Grace, though. She said pretty much everything that needs to be said, in my opinion. Okay, so I was asked to speak about Ehlers-Danlos syndromes and hypermobility spectrum disorders, past, present, and future. So, and my subtitle is, if you can't connect the issues, think connective tissues. You've probably all heard that phrase before. I attribute it to Dr. Heidi Collins, who's a colleague also in Indiana. She's in South Bend, Indiana, and one of the true experts in the hypermobile type of EDS. So I'll start with the past. How did we get here? And I actually have to start off, well, Dr. Chip Norris told me today that this slide is incorrect because he explained to me that Hippocrates actually was the very first person to describe hypermobile Ehlers-Danlos Syndrome in the year about 400 BC. So I left that. I mean, it's not included on here, but you should all know that. In 1892, a Russian scientist named Chernagabo reported 2 patients with joint hypermobility and skin laxity, and there are many people who argue that really this syndrome should be named after him because he was the first guy. But he published in Russian, and his contribution didn't really come to be widely recognized until much later. So then in 1901, Edward Ehlers described a patient with joint laxity, unusually stretchy skin, a history of easy bruising, frequent knee subluxations, and delayed walking. And a dermatologist, Henri Alexander Danlos, collaborated with a guy named Pautier to delve further into the physical manifestations of what later came to be known as the Ehlers-Danlos Syndrome. And in the United States, the first case was reported by Tobias in 1934. And then in 1936, there was a report about 24 cases by Roches. There were 24 cases in the literature, and he himself had seen 3 personally. So slowly there started to be built up a literature about this condition. And then Johnson and Falls published pedigree suggesting that the condition was inherited as an autosomal dominant trait. That was in 1949. Dr. Victor McCusick in 1956 published the first edition of a book he called Heritable Disorders of Connective Tissue. And Dr. McCusick was really the first person to recognize that there were a group of disorders that involved the connective tissue that also manifested in multiple different organ systems, because he recognized that the connective tissue was present in so many different organ systems, and that a disorder of the connective tissue could therefore present in many different ways. So in genetics, we call this the phenomenon of pleiotropy, where you have a single variation in the DNA, but it's represented in multiple different tissues. So McCusick's first edition of Heritable Disorders of Connective Tissue listed fewer than 100 cases of EDS at that time. And then by the time the third edition was published in 1966, there were over 300 reports, and people had started to recognize that, wait a minute, this is not just one condition. There are likely different types of this, that there are people who have joint hypermobility, but they have joint hypermobility plus different things, different other manifestations. So likely these are not all a homogeneous group of disorders. And then in 1972, Sheldon Pinnell and his colleagues found that there was a deficiency of lysyl hydroxylase, an enzyme called lysyl hydroxylase, in an autosomal recessive form of Ehlers-Danlos syndrome that we now recognize as the kyphoscoliotic type of EDS. So that was the first biochemical difference that was recognized as an underlying cause of a type of EDS. So that leads us into the classifications of the different types of EDS. In 1988, there were 9 different types, and those were the ones, that's when those Roman numerals came out, that, you know, we call them types 1, 2, 3, 4, for the, what we now recognize as the classical hypermobile vascular types. And that classification was simplified, and then they applied names to them. So that was in 1988. And then we had a long hiatus, almost 20 years, before another classification came out, and that was the current classification, which was published in 2017, including 13 different types of EDS. And the hypermobility spectrum disorders were added in 2017 as a category of heritable disorders of connective tissue, recognizing that there are people who have joint hypermobility who do not meet the current diagnostic criteria for hypermobile Ehlers-Danlos syndrome, but struggle with many of the same comorbid conditions that we see in people with HEDS. So pretty much that brings us up to the present time in terms of the classification of these conditions. So what do we know now? What's the kind of universe of EDS that we're living with in 2022? Well, we know that these are a group of heritable disorders of connective tissue, that they all involve the connective tissue, and we have these 13 different types that were described in the 2017 criteria. And these have a wide range of varying presentations. The underlying genes for 12 of these are known, and all of them are genes that they either affect the proteins that are involved in making the connective tissue, or they affect the enzymes that are involved in processing those proteins. And right as of this moment, the genes underlying the hypermobile type of Ehlers-Danlos syndrome are not yet known, but as you all know, there's a lot of work going on to try to rectify that situation. So what these 13 different types of Ehlers-Danlos syndrome have in common, they all involve the connective tissue. Joint laxity is a feature in all of them. The skin is involved in most of the different types, and skin fragility, skin hyperextensibility, stretch marks, poor wound healing, easy bruising, those are the common features that we see in the skin. But many other organ systems are involved to varying degrees in the different types of EDS. So I'm just going to say a little bit about connective tissue. It's literally the material that holds the body together. It's found in every organ system in the body, and examples of connective tissue are the tendons, the ligaments, the dura that surrounds the cerebrospinal fluid and the spinal cord and the brain, bone, cartilage. There's a special kind of connective tissue that's called subcutaneous connective tissue that sits right under the skin. And collagen is the predominant protein of connective tissue. There are many different types of collagen, but there are also molecules called proteoglycans, and those require the addition of sugars to the protein background to be complete. And there are many genes that encode these proteins, and there are enzymes, there are genes that encode the enzymes that process them that may cause the different types of EDS. And this is just a little bit of an illustration. You can see in the upper left-hand corner the illustration of the different types of connective tissue. And then under that illustration is a schematic showing how the proteoglycans are put together with a central core, protein core, to which are added a number of different sugars. So the enzymes take different types of sugars and they attach them to this protein core. And the type of sugars and the orders in which they are added specify the different types of proteoglycans. So you can see we've got heparan sulfate, chondroitin sulfate, dermatan sulfate, and it's just they differ by these chains of sugars that are added onto that protein core. And then the collagens, the signature structure of the collagens are a triple helical molecule, and so there are 3 chains that wind up in a triple helix to create the helical region of the collagen molecules. And then those triple helices line up and they stack in a very particular order, and you can see under the electron microscopy that there's a real periodicity to that, and they have a very typical appearance under the microscope and the electron microscope. So inheritance of the Ehlers-Danlos syndromes may be either autosomal dominant or autosomal recessive. So for some of the rarer types, we have autosomal recessive inheritance, where you need to have two parents who are carriers, and then the affected child inherits a variant copy of the gene from each parent. The classical, hypermobile, and vascular types of Ehlers-Danlos syndrome are inherited as autosomal dominant conditions, which means that one only needs a single copy of the affected gene with a variation in it that causes the disorder. And the person who has that condition then has a 50-50 chance of passing it on each time you have a child. And these are the different types of Ehlers-Danlos syndrome. You can see that most of the rarer types are inherited as autosomal recessive. AR stands for autosomal recessive, and the AD is autosomal dominant. And my colleagues at Johns Hopkins put together this daisy, which I really like as an illustration of the different types of Ehlers-Danlos syndrome. And you can see each petal on this daisy represents a different type, and the genes that cause each of the different types are represented in the petals. And right here with the, here's our hypermobile type, unknown. This will soon be changed. So hopefully we'll have a gene to put there for you next time we talk. So we use the 2017 diagnostic criteria to diagnose the Ehlers-Danlos syndromes. And because the hypermobile type, which is the most common type, we still don't have a molecular test to offer for that. We rely on the clinical diagnostic criteria in order to make a diagnosis. So those clinical criteria are listed on the HEADS diagnostic checklist on the Ehlers-Danlos Society webpage, and many of you have probably seen this and maybe even gone through it with a clinician at one time or another. Criterion 1 is generalized joint hypermobility, and we use the Beighton score to establish whether a person has generalized joint hypermobility. One of the things that came out of the 2017 diagnostic criteria was a recognition that we should not be using the same cutoff for people of all ages because of the changes that happen just naturally in joint hypermobility with aging. So we use a cutoff. The Beighton score has a total of 9 points. And you have to have 6 of those points if you're prepubertal, 5 points if you're a postpubertal adolescent or man or woman up until age 50. And if you're over the age of 50, then a score of 4 or more is sufficient to establish a diagnosis of generalized joint hypermobility. The committee that was thinking about this also said, well, sometimes people just, like, they're 1 point shy, but they have a lot of other things going on that really look like hypermobile Ehlers-Danlos syndrome, and they might need just like a little bit more information to kind of push them over the finish line. So this committee turned to a 5-point questionnaire, which has been published and validated in the rheumatology literature to establish whether or not a person has joint hypermobility. And they decided if people answered yes to 2 or more of the questions on the 5-point questionnaire, we could give them a bonus point for joint hypermobility. And so if they're 1 point shy on the Vitin and they have 2 questions positive on the 5-point questionnaire, we can kind of get them over the edge and say, yes, they have generalized joint hypermobility. So those questions on that 5-point questionnaire are, can you now or could you ever place your hands on the floor without bending your knees? Can you now or could you ever bend your thumb to touch your forearm? I love this. As a child, did you amuse your friends by contorting your body into strange shapes? Or could you do the splits? As a child or teenager, did your shoulder or kneecap dislocate on more than one occasion? And finally, just plain simple, do you consider yourself to be double jointed? Now you can see that the first 2 of those overlap with the Vitin scale. So a person might conceivably get 2 points for being able to put their palms on the floor, right? So there's some contention among geneticists about whether or not it's reasonable to do this. And maybe the next time we have a diagnostic criteria come out, it may look a little different. But for now, that's the way it's written. And this is a really nice illustration, I think, from the UK Ehlers-Danlos support group, Ehlers-Danlos Support UK, just showing how we measure the Vitin score. We get 1 point each for 1 point for putting your palms flat on the floor. I don't really like the way they're illustrating this, the little finger. I usually ask people to hold their hand flat like this and then push back this way. I don't go beyond 90 degrees, but I use the thumb of my other hand to hold the 4th finger flat and then see, can I create a greater than 90-degree angle at the 5th metacarpophalangeal joint. 1 point each if you can touch your thumb to your wrist, and 1 point each for hyperextension beyond 10 degrees of hyperextension at the elbows and the knees. So those are the 9 points. Now criterion 2, we need 2 out of 3 features. And this first feature A is a list of 12 findings, and to say that that's positive, we need 5 of those 12. So for criteria 2, you can either have 5 out of 12 for feature A, or a positive family history where 1 or more first-degree relative actually meets the diagnostic criteria independently, meeting the current criteria for hypermobile EDS. And then feature C is you have to have 1 of the following: the musculoskeletal pain in 2 or more limbs daily for at least 3 months, chronic widespread pain for at least 3 months, or recurrent joint dislocations or frank joint instability in the absence of trauma. So 1 of those. So we either need A and B, B and C, or A and C to say we're meeting criterion 2. And then finally, criterion 3 says that we have done our due diligence. We have thought about it, what we call a differential diagnosis. We've thought about all the other possible explanations that might result in the clinical picture that the patient we're seeing at the moment is presenting to us. So if we've been through all that and we say criterion 1, 2, and 3 are met, we can make a diagnosis of hypermobile Ehlers-Danlos syndrome. And I just show these slides because one of the things we're thinking about for criterion 3 is there anything that's making me worried that this might be one of the other types of Ehlers-Danlos syndrome? So the typical scarring, on the far side, you can see the typical scarring on the shins that would be very suggestive of the classical type of Ehlers-Danlos syndrome. So if I was seeing a patient and they met all the criterion 1, criterion 2, but they had these looking shins, I would say let's do some genetic testing for the classical type of EDS. And same thing, if they have this kind of stretchiness of their skin, this is very atypical for the hypermobile type of EDS. This is much more suggestive of the classical type. So we call them red flags. Anything in the family history that suggests another hereditary disorder of connective tissue, or anything in the personal history or on the physical exam that I think is a little bit outside of what we usually see in hypermobile EDS, then we start thinking about genetic testing for alternative diagnoses. And just a couple of words about the spectrum of joint hypermobility. I'm sorry this is so small, a little hard to read, but the spectrum of joint hypermobility runs from asymptomatic to symptomatic, and the type of joint hypermobility that people have may be generalized, so they meet the Beighton criteria for generalized joint hypermobility, or it might be peripheral joint hypermobility, so just in the digits of the fingers and toes, the small joints of the fingers and toes, that's considered peripheral joint hypermobility. Or it might be localized joint hypermobility. A person might just have one or two joints that are subluxing or dislocating or unstable in some way. And so GJH is generalized joint hypermobility, PJH is the peripheral joint hypermobility, and LJH is localized joint hypermobility. And any of those may be asymptomatic, which is great, right? But if people are suffering, if they have symptoms, then they start falling into the hypermobility spectrum disorder, which may be generalized, peripheral, or localized. Someone may also have symptoms and the comorbidities that we associate with EDS and HSD and not demonstrate hypermobility on their current exam, but they may have been hypermobile in the past. And we call that historical hypermobility. If it's presenting symptomatically with the comorbidities, then it's historical HSD, or HSD, which is confusing because the HEDS is hypermobile EDS, so it's lots of H's here. But at the far end, then we have the people who meet those 2017 criteria that I just went through have hypermobile EDS. So I don't need to tell this audience that EDS and HSD are not just bendy joints, which is what a lot of people still think in the emergency rooms and many internal medicine offices throughout the country. And the symptoms presenting in hypermobile EDS and HSD may affect virtually every system in the body. And we come back to Heidi's admonition that if you can't connect the issues to think connective tissues. So just a quick run through of how we think about some of these things system by system. In the cardiovascular system, the orthostatic intolerance may be a result of postural orthostatic tachycardia syndrome or neurally mediated hypotension. You may see mitral valve prolapse on an echocardiogram. There may be very mild aortic root dilatation. For the hypermobile type of EDS, we do not expect a very large dilated aorta. If we see that, we worry that it might be something else. We need to go looking for other hereditary disorders of connective tissue. And also in the cardiovascular system, on the venous side, we may have venous insufficiency. So you may have venous pooling in the legs. You may have venous insufficiency with diminished venous draining from the head. So in general, treatment strategies that we think about in the cardiovascular system, we want to make sure people are getting enough water, getting enough salt. If the orthostatic intolerance is reported, compression hose or other compression garments may be helpful. I've been recommending the new one, NUUN active hydration tablets or salt stick capsules to help replete salt. And rarely we see people who are having arrhythmias that really require cardiovascular intervention. We have to send those people to Dr. Judge. And it's important to remember also that mast cell activation may exacerbate the symptoms of dysautonomia. So you want to make sure if somebody's having dysautonomia that you ask the questions about, do they have rash, do they have hives, is there anything suggestive of mast cell activation in those people, and make sure they're treated appropriately. Because the dysautonomia and the mast cells, they exacerbate each other. The mast cells make the dysautonomia worse, that makes the mast cells worse, and you go right down that downward spiral. Now, in the neurology department, there are so many different issues related to neurology in hypermobile EDS. I've heard Fraser Henderson give a lecture talking about headaches in hypermobile EDS. He listed 13 different types of headaches. So CSF pressure variation, it might be high pressure or low pressure. There are muscular contributions to headaches in EDS, migraine, and neurogenic if the C2 particularly is compressed, that can cause pretty bad headaches. We see a clinical entity that's called cervical medullary syndrome caused by Chiari malformation or craniocervical or cervical instability. And the autonomic dysfunction is definitely a neurologic thing, neuropathic pain, small fiber neuropathy, or that people have adequate nutrition. So we try to minimize the use of proton pump inhibitors, and we supplement vitamins as needed if they are deficient. Symptoms we see in the genitourinary system. You may have urinary urgency, frequency, burning on urination, difficulty initiating the urinary stream is something we see with tethered cord, difficulty emptying the bladder completely, urinary dribbling or frank incontinence. Somebody may report that they have frequent urinary tract infections. They feel like they have urinary tract infections, but when they go and they get cultured, the culture actually comes back negative. There's no bacteria, it just feels like an UTI. Pelvic floor dysfunction is a function of, because the pelvic floor has, guess what, connective tissue, right? So to hold those pelvic organs in place, sometimes the pelvic floor just doesn't have the strength, and as a result, pelvic pain can be a serious problem. So when we do the examination for this, we're looking for tenderness over the symphysis pubis and the kidneys. You do the urodynamic testing that I mentioned earlier to look for the neurogenic bladder. And the pudendal nerve is another nerve that's compressed in tethered cord. So sometimes we can do pudendal nerve conduction studies to look for evidence of compression at the tethered cord region. And then urogynecologists those are the specialists who look at the pelvic floor, look at the pelvic floor muscles. And then we also want to wonder about, are the mast cells, those nasty mast cells, they can get involved almost everywhere. If you're having what seem like urinary tract infections, but they're culture negative, that may be interstitial cystitis, and that is a mast cell phenomenon. We offer pelvic PT for pelvic floor dysfunction, the mast cell protocol if interstitial cystitis is suspected or diagnosed, and then if the urodynamic studies are indicative of a neurogenic bladder, and the tethered cord questionnaire and physical exam are suggestive of a tethered cord and refer to neurosurgery. So allergy, immunology, and hematology. We're working our way through the textbook of medicine here, ladies and gentlemen. We ask about a history of hives, rashes, flushing, itching, frequent infections, severe allergies, autoimmune disorders, and a history of blood clots. All of these can be seen. On exam, we're looking for the presence of flushing. Sometimes I've seen somebody come in and their ear, just one ear, is bright red, like fire engine red. Sometimes you see flushing on the chest wall. You look for dermatographia, where you just take your fingernail and run it along the skin. There's a red wheal arise on the skin. That's dermatographia. And then if people tell me that they have a history of frequent infections, they're always homesick, multiple strep infections or whatever, an immunologic workup to look at levels of antibodies, and they're basically, is the immune system doing its job? Do they have the antibodies that they should have from immunizations that they might have gotten as children? And are their T and B cells working properly? So if it turns out that they have a predisposition to thrombosis or thrombophilia, some patients may wind up on anticoagulants. I'm really interested in this Walls protocol by Dr. Terry Walls. She's been using basically what is a ketogenic diet for autoimmune conditions, and seems to be having really good results with that. She was an N-of-1 experiment for herself with severe systemic lupus, and got herself back from being really totally disabled to being able to get back and function properly with this nutritional intervention. IVIG or plasmapheresis may be necessary. if you've got a severe autoimmune encephalitis or immune deficiencies with low immunoglobulin levels. And people are starting to use IVIG now for peripheral neuropathy as well, the small fiber neuropathy. And we want to make sure people have adequate levels of vitamin D. The normal ranges for vitamin D may go as low as 20 in some laboratories, but my colleagues in rheumatology and also in immunology are saying that we should really shoot for a target between 40 and 50 nanograms per deciliter. And again, this should be lower. Now, patients with higher gastric pH, yes, with less acid in their stomach, we need increased supplementation to achieve therapeutic levels. So if we do suspect the mast cells, this is what I call my mast cell 101. Before I refer to allergy and immunology, I try people on H1 and H2 blockade. So these are medications that block the H1 and H2 receptors for histamine. And actually this slide is out of date. We're not using Zantac anymore because it has been taken off the market. So instead of the Zantac 150, it should be Pepsid, 20 milligrams twice a day. And then cromolyn sodium stabilizes the mast cells. This is a medication that is a light-sensitive liquid. So it's distributed in little 5 ml vials that you break and you mix them in a small amount of water and you drink them half an hour before meals and at bedtime. So distributing medication in little 5 ml vials is the least efficient means of distribution of a medication known to humankind, and it is therefore extremely expensive. Okay? So a lot of insurance companies don't like paying for cromolyn sodium because it is so expensive. I have recently learned that you can get cromolyn sodium compounded, and you can get it made up with 100 milligrams, which is the amount that there is in one of those little 5 ml vials, and it's compounded in 100 milligram capsules and costs considerably less as a compounded product than it does to buy this commercially available light-sensitive liquid. So that's something to think about if somebody's recommending cromolyn sodium to you and it's prohibitively expensive. See if you can get it compounded instead. And another alternative for mast cell stabilization is quercetin. This is a herbal product that also stabilizes the mast cells, and you can use 500 to 600 milligrams of that 4 times a day. That's available over the counter. You can get it at Whole Foods or a lot of different supplement stores or on Amazon. I've been recommending to people to try this low histamine diet. Now, there's controversy about this. Some people don't think that it's useful, but I've had enough patients tell me that they've done well after trying it that I still think it's worth a try. This website, Histamine Intolerance, is a Swiss website. It'll translate into English or French or German. It gives a long list of foods, each of which is labeled thumb sign is the Murdoch sign. So you might see those referenced in that way. Now, these are the recommendations that I make for the musculoskeletal system. We want to stabilize unstable joints on an as-needed basis. So if you're just stabilizing when you need stabilization, you're not going to cause weakness in the muscles. But you don't want joints in braces all the time. Physical therapy for muscle relaxation, that'll include deep heat, ultrasound, massage, use of electrical stimulation, far infrared laser therapy. Our muscles have to relax before they can do the work to tone and strengthen. So if they're in spasm and you're trying to exercise them, you're going to do more harm than good. So it's very important for the PT to work both to get muscles to relax and then to do the toning and strengthening effort. Myofascial trigger point, dry needling. If the TENS machine is helpful in the PT office, these are available for home use now. They used to be super expensive, but they're really not anymore. You can get a really good one called the TENS 3000 for about $30 on Amazon. The PT for toning and strengthening the muscles, particularly aquatic PT, can be very, very helpful for people with hypermobility. I prescribe this compounded analgesic cream. It's a combination of 6 different ingredients, and many patients find this to be helpful. Again, insurance sometimes really balks at paying for these. There's an alternative that I've been using lately, which is called Pain Terminator. It's available on Amazon, and this is a combination of different Chinese herbs. They make a cream, and they also make patches. So the patches are really good for putting on if you have back pain, or you can put them over the trapezius muscle. And the cream is better for bendy places like elbows and wrists and knees. So coping with chronic illness, I don't have to tell this crowd, this can be very challenging. Cognitive behavioral therapy can be helpful. I'm a big fan of mindfulness-based stress reduction, and you used to have to go for each week, you'd go for a 2-hour session to learn about mindfulness-based stress reduction. Dr. Palouse has put all of those sessions online now at palousemindfulness.com, totally free, and you can do it in the comfort of your own home at no cost. Biofeedback and neurofeedback can be helpful. The patient support groups, including Bobby Jones Chiari Syringomyelin Foundation and the Ehlers-Danlos Society, can be really helpful. And then you want to be exercising. It's just really important to keep moving. Moving is good not only for the musculoskeletal system, but also for our brains and our mood. So you want to get at least 30 to 40 minutes of low impact activity most days of the week. Walking, biking, elliptical, rowing, any water exercise. If you're in the water and turning your head is a problem, you can just put a kickboard and use a snorkel and just kick your way around through the pool. All right, where are we going into the future? So I'm really optimistic, I have to tell you. I'm more optimistic now than I ever have been about what the future holds for patients living with the Ehlers-Danlos syndromes. There is an army of scientists and doctors and patient support groups who are working tirelessly to try to improve the quality of life for people with EDS. And the International Consortium on EDS and Hypermobility Spectrum Disorders will be meeting in Rome in September of this year to kind of update what's happening, what's going on, what research is being done. I think we're going to hear a lot. It's going to be very encouraging. There's information about the International Consortium on the Ehlers-Danlos Society webpage, which is ehlers-danlos.com. The International Consortium has a long list of working groups that are all working together to do literature reviews, put together diagnostic pathways, and develop common data elements so that we can all be using a common language to describe the research that's going on. The upper left-hand corner is the website from Dr. Norris's lab, and I'm telling you, it is so exciting to see what is going on there. It's really, really, you guys, it's fantastic. So Dr. Norris and his team of amazing people have a registry that's collecting information about patients with EDS, and they're doing really cutting-edge work to try to identify the genes involved in hypermobile EDS. And the Ehlers-Danlos Society has a global registry that's also collecting information and collecting phenotypic information and promoting research for EDS and HSD. There's a group of patient support groups working together as what we call the Community Coalition to develop research initiatives and develop combined requests for applications so that we can promote a common research agenda. And the Hypermobile EDS Genetic Research Network is a bunch of people from all over the world working together thinking about how can we find these genes that we need for the hypermobile type of Ehlers-Danlos syndrome. In addition to the work that Dr. Norris is doing, the Ehlers-Danlos Society is sponsoring the HEDGE study. Many of you may have participated in that one as well. And we've collected 1,000 DNA samples from people with hypermobile Ehlers-Danlos syndrome to do whole genome studies, whole genome sequencing for that one. And then we also have Project ECHO, which is a means of providing information to practitioners who are taking care of patients with Ehlers-Danlos syndrome and hypermobility spectrum disorders. And I think this is a means of moving positively toward the future to develop an army of doctors who are familiar with EDS and have the knowledge that they need to take the best possible care of people with EDS and HSD. The Ehlers-Danlos Society has given over $6 million in research funding over the last 5 years. For research to get done, you need the money. You know, it's not going to happen without the funding, but when you offer the funding and people are stepping up and putting forward projects, we're learning more and more as time is going by. So when you look at the number of publications about Ehlers-Danlos syndrome over the last 10 years, there is a really beautiful curve of increasing knowledge that's going on there, and it's really, really nice thing to see. So if you go to the Ehlers-Danlos Society webpage, you can look at all the projects that they funded, and more and more information is coming out as a result of that. So the bottom line, it takes a village. We need more and more people, multidisciplinary evaluation and management for patients with EDS and HSD. We still have so much to learn about the underlying biology in these gene finding studies that are being done in the Norris lab and as part of the HEDGE study are going to give us those first clues to help us figure out, okay, what is the biology behind these conditions? What is the biology behind the comorbidities? And once we understand the biology, we can start thinking, how can we treat this? Right now we're treating symptoms. We want to get to the underlying problem and knock it out. So we really need new strategies for treatment, and I'm very, very optimistic that these studies that are being done now are going to get us to that place. So thank you so much for your attention, and I'm happy to take some questions.
Any questions for Dr. Francomano?
Just given the number of different comorbidities and the fact that most of these things are still being diagnosed clinically, how do you as a clinician determine what symptoms are being caused by what?
So it's challenging. I have a set of symptoms that suggest certain things to me. So as I mentioned, if somebody says to me they're having abdominal pain, gas, bloating, diarrhea, particularly if they know that it's related to food sensitivities, I will go down the Mast Cell 101 trial route before I do anything else. If the mast cell medications are not effective, then I have to refer them to a gastroenterologist. If there are other symptoms, like if it's constipation, really bad constipation, and it's in the setting of other symptoms that make me worry about a tethered cord, then I'll do the urodynamic testing, and sometimes we do a MRI of the lumbar spine. We do it in lying down face forward, and then also turn around and lying down face up, and see whether in the face forward position the cord drops to the front of the spinal canal. So that's another way of looking for the tethered spinal cord. And then we can also, if the urodynamics show a neurogenic bladder, then we go down that route. But yeah, need a really good relationship with a gastroenterologist. You know, my guy in Indianapolis, his name is John Wu. It's W-O, but it's pronounced Wu. And I can send him a message and say, I have this really puzzling thing, what do you think? Like, in Who Wants to Be a Millionaire, you get to call a friend. There was a question that came in from somebody ahead of time had sent in a question asking if a person has joint hypermobility but they don't meet the Beighton score and they have all these comorbidities, would you still consider it to be hypermobile EDS, and is it like a requirement to have a positive Beighton score to call it hypermobile EDS? And if you go by the letter of the law, kind of like strictly by the book, I would say that that is a requirement. The Beighton, you really need to have generalized joint hypermobility in order to call it either generalized joint hypermobility, generalized HSD, hypermobility spectrum disorder, or hypermobile EDS. But sometimes it just looks and feels so much like hypermobile EDS to me that if a person is 1 or 2 points below and they've got really super flexible shoulders and hips, for example, I'll still call it hypermobile EDS. So I think it varies, and different people are going to have different cutoffs where they'll call it different things. But if a person has localized joint hypermobility and they have all the symptoms associated with EDS and HSD, it would then become the localized hypermobility spectrum disorder. And so we do have names. Going by the book, we have names that we can apply to these various situations where somebody, if they don't meet the generalized hypermobility criteria, they might meet either the localized or peripheral or even historical hypermobility, and then you can call it historical hypermobility spectrum disorder or localized hypermobility spectrum disorder. Any question?
On the heels of that question, if you have a parent who has, since this is very sensitive, talking about myself, a parent who has the HEDS, but the child who's been misses the Beighton score cutoff, how do you handle, like, the children, my fear is they're going to go 50 years like I did, undiagnosed, and, you know, my daughter has a tremendous amount of comorbidities, especially brain malformations, and so my thing is I guess I want to have her continue to be watched because I fear that is, so how do you handle patients like that don't quite meet the cutoff, but I'm fearful that it could at some point.
Right. So there's a committee, one of the working groups in the International Consortium is the Pediatric Working Group, and they've been really working on thinking about how do we define the diagnostic criteria for children. Because children, in general, are much more flexible than the average adult. And also, many of them will not have had surgery, so we're not going to see whether they have atrophic scarring or not. Especially if they're young, they may not have developed stretch marks yet. So these criteria don't really work that well for children. And the pediatricians tend to be leaning towards using that hypermobility spectrum disorder label for kids if they don't meet the diagnostic criteria. And then, but also maintaining the diligence or vigilance so that, you know, the symptoms are recognized as they emerge and that they're treated as they emerge. And also that preventive measures that can be taken to try to avoid high impact activities. For example, that we try to guide them towards the lower impact activities so that we can perhaps minimize some of the effects of the hypermobile joints as they get older. Yes?
Can you speak a little bit about cerebral venous insufficiency and what you see in elaborate on that?
So one of the causes of increased pressure in the brain is if the blood is not draining properly from the brain. So there might be veins in the cerebral circulation that are poorly developed. If you do MR venogram that looks at those veins structurally, there may be just congenitally a narrowing of the veins. And then the blood isn't getting out. Now there's a complex interaction between the cerebrospinal fluid and the blood circulation in the brain. The cerebrospinal fluid is absorbed, and then the liquid actually gets removed from the head by means of the circulatory system, as well as circulating throughout the spinal canal, and it circulates around, the cerebrospinal fluid circulates around the brain and goes through the brain and then goes all the way down the bottom of the spinal cord and comes back up. So if the blood is not leaving the brain adequately, if it's getting stopped up because the veins are not adequate, then you can see increased intracranial pressure. And so it's controversial. There was one surgeon who was doing a lot of stenting for narrowed veins in the brain, and some of those procedures did not go well, and so people have kind of been leery about that as a procedure. So I think there's a lot of work that still needs to be done to understand why that's happening and also what are our best strategies for dealing with it.
Okay, is there any way to check online? Are there any questions?
No.
Okay. Okay, so if there are no more questions, let's thank Dr. Francomano for and thank you all for taking time out of your day to come here to the talk.